Good morning, Professor Steve and Dr. Huber. I am Arhan Cheng, and thank you for the opportunity to present my project. I'll be talking about how musculoskeletal simulation can help explore ways to improve tibialis posterior tendon transfer for patients with foot drops. Foot drop is a condition where patients can't lift their front foot, and this makes them more likely to trip or fall and can affect their safety, confidence, and quality of life. For these patients, tendon transfer surgery is often the last resort to help them restore muscle function. My aim in this research is to evaluate the key decisions made during tendon transfer surgery and identify the most effective technique. And to make things clear, I focus on three main steps: the opening height, the rerouting, and the insertion point. I use a pre-built model in OpenSim to simulate the surgery. I then analyze the biomechanical parameters in the ankle and subtalar joint. Finally, I compared my simulation results with clinical study to evaluate my findings. And the results are split into three parts. First, in terms of the routing pathway, I found that the interosseous route produced a greater dorsiflexion moment arm and offered more balanced foot movement compared to the circumtibial route. Second, when looking at the rerouting height, I found that the dorsiflexion moment arm increased as the height went up and plateaued around 9.65 centimeters. This suggests a sweet spot where muscle tension and biomechanical benefit comes together. And finally, for the attachment point, the classic method, which inserts the tendon into the media of the foot near the clavicular, generate a more balanced and stronger dorsiflexion moment arm compared to the more lateral modified cuboid insertion. My simulation findings strongly aligned with previous cadaveric and clinical studies. This supports the overall design and validity of my study. However, when it comes to the attachment point, my model favored the classic navicular insertion, but interestingly, clinical studies such as the one done by Selig in 2008 reported better clinical outcomes when using the modified cuboid insertion technique. And the difference between what we see in simulation and what happens in real life is likely due to several factors that were not included in current model. First of all, the soft tissue interaction and also the neuromotor readaptation, where a patient has to relearn how to use the rerouted muscle. And finally, adjunct procedures such as Achilles tendon lengthening and osteotomies are also not included in current models. Building on this research, there are three key directions I'd like to suggest for further future work. First of all, we could move beyond current model and apply forward dynamics using tools like OpenSync Moco. We could also apply reinforcement learning like OpenSync RL to model post-operative neuromotor adaptation. And secondly, it is also important to personalize patient model with CT or MRI segmentation. And finally, a close collaboration with orthopedic surgeons to collect intraoperative measurements and clinical data will help us create a more accurate replication of the surgery and validation of the outputs. In this study, I demonstrate how we can how we can explore surgical options in a safe and ethical way before stepping into the operating room. Eventually, the goal is to build a decision supporting tool that can be used for pre-surgical planning. Uh, And finally, I just want to thank everyone who supported me through the past year, a past amazing year, and thank you, Steve and Huben, for taking the time to read my dissertation and being here with me today. And I'm happy to take any questions. Thank you.